We're here at the International Conference in Vienna with Ian McGowan, who is the Professor of Medicine at the University of Pittsburgh. And we just concluded the Caprisa study presentation in the press room. And we're still astounded, maybe it'll all register over the night and the next couple of days, the meaning of this. And part of that meaning is, what does it mean for men who have sex with men? How will we move forward as quickly as we can to develop protocols and whatever is necessary to prove usefulness, to examine usefulness in men?
It's a good question because there's clearly a need both for men who have sex with men in the developed and developing world, but as you're well aware, there's increasing epidemiological evidence that women often have anal sex in different parts of the world,
right.
and so this is an area where we need to develop products both for vaginal and rectal use. I think today was a great day for the field because, perhaps surprisingly to some, there are a lot of skeptics out there, and I think in the treatment community, maybe in the vaccine community, who thought the idea of applying, as they would call it, gloop, topically, how could you ever imagine that would interrupt HIV transmission? And I think the Caprisa team today showed magnificently that yes, indeed, when you select a population of women at high risk, you give them the drug, it works. And so I think that's going to galvanize the field, and I think that'll have ramifications both for further vaginal development and hopefully eventually a licensure of a product. But also I think the buzz already is, well, what about rectal microbicides? So, that field has been gathering momentum a lot too. Earlier this year I co-chaired the Microbicide 2010 conference in Pittsburgh, and a theme of the conference really emerged was the need to develop rectal microbicides. It's always been seen as a bit of a peripheral area in prevention research, but I think it's becoming much more mainstream. We've completed a phase 1 study of UC781 rectally. We've just completed, importantly in the context of today, a very detailed phase 1 safety, pharmacokinetic and pharmacodynamic study of tenofovir given rectally. That study just completed a month ago, so we're going into data analysis. But that's going to tell us about the safety of the product when given rectally, the clinical safety. It's going to tell us about the distribution of the drug when it's given rectally. And importantly, this concept of pharmacodynamics. We've actually taken biopsies from these individuals and seen whether or not the biopsies, when they're treated in vivo with drug, will resist infection in a test tube. And we're about to start the next tenofovir study rectally. So I think this week's going to move us ahead more quickly.
The question that pops into my mind immediately is that it makes sense to have a single product that would be useful either way. As you said, with male and female, who knows how the sexual experience is going, that particular sexual experience is going to unroll. And so I think that would be certainly the one thing to do, in addition to everything else you might be doing. But I'm wondering about you suggested other than tenofovir, what other products might there be, and what other, it doesn't necessarily need to be maybe an antiviral. It may be something else that would be other than an antiviral for
I think in drug development there's a certain level of pragmatism. You work with what you have.
Right.
So we used tenofovir because it had matured so much as a vaginal product. And it made sense to test it for safety. That's the reason we did the study.
Right.
I will say, although the study analysis has not been completed yet, there was a suggestion that maybe it wasn't as well tolerated rectally as it was vaginally, perhaps because it's a very concentrated gel. And when you put a gel into the rectum, it may draw water in and perhaps cause some side effects. In our second tenofovir study we're going to do rectally, we're using a newer formulation of the product, which has been made to be much less concentrated in terms of what we call the osmolality of the product, how sort of viscous.
It is more viscous now than it needs.
It's less.
Oh, it's less.
The current version, the vaginal version suits the vagina, but we've created, or rather our colleagues at Conrad have created a version where the concentration of drug is the same, but the actual formulation is less concentrated. So it may be better tolerated.
You say it's more viscous.
No,
it's less viscous.
Less,
oh, okay,
yes.
all right.
Because
I felt it. I think everyone got a little bit of a touch of it, and it seemed just like KY jelly.
Exactly.
Yeah.
But as you probably know, that's a whole other topic for another day. But the lubricants as well, very, very much in their characteristics and their suitability for rectal administration. We generally say that body fluids isoosmolarity is about 300 milliosmoles. Some of these products are 3,000–4,000 milliosmoles. So they're 10 times the normal concentration of body fluids. So you can imagine that may have some repercussions, and suggests why we need to tailor the products for where they're going.
Exactly. Well, then I just have a sense of reality here, and people that are using products kind of haphazardly. And my understanding is that you're going to have to be very careful, follow the prescription, so to speak, or the directions, and understand how to use this if you want to be protective. I know there were some very specific ways in which they ran this trial. So presumably, I mean, it may work different. You know, there may be other opportunities to change or vary from that, but I think that's part of the big picture.
I think the bottom line with this class of drugs, the antiretrovirals as microbicides, is, as Craig Hendricks would say from Johns Hopkins, you know, you've got to have the right amount of the drug in the right place at the right time for as long as it's needed. In other words, you have to have enough drug there. And I think that's the key thing. So that brings into question then whether people should use it on a daily basis, on an intermittent basis, just before sex, just after sex, the both. We need studies to try and define this, and we are doing those studies to a large extent. Some of the phase 1 studies I mentioned are really looking carefully at the relationship between dosing strategy and concentrations of drug in different compartments.
Can you say something, I didn't ask your permission to do this, but I would ask you maybe to talk just a little bit about prevention as it is today. We know that what we're looking at in microbicides is a little ways off, even though we had a win today, a big win.
Yes.
Where do we go? What do we do? How important is it, people now especially, to be concentrating on prevention and aspects of prevention?
Yeah, you know, I mean, I always say to people and to patients, and you know, at the end of the day, we have some interventions which we know work, and others which just, I think, from a public health perspective, are likely to be beneficial. They're not very exotic. It's almost common sense. But, you know, of course, we come back to use a condom, and some people can't or won't. You know, have regular checkups for STIs and have them treated. You know, perhaps a new thing would be to use a suitable lubricant with a more isoosmolar profile. Get circumcised if you're not circumcised. These are other things to do. You know, maybe cut down on the number of partners, the type of sexual repertoire. Until we have a vaccine or until we have a real microbicide, I think all of those things play an important role.
It may be here before we know it.
And it may be here before we know it. But meanwhile, you know, there's a bit of a swirl at the moment in the MSM-OMA community about lubricants. And really the swirl's coming from guys who are unwilling or unable to use a condom in the context of receptive anal sex, but have some worry about whether one lubricant or another may add extra risk. And to me, it seems a bit of a fallacious argument. If you're saying, I won't use a condom, why should you then be worried about the sort of this incremental change in risk that might result from which type of lubricant you use? But I think that's just an illustration of we've still got a lot of work to do, remind people, you know, about common sense things they can do to reduce personal risk. Well,
is there anything else you, I mean, I saw the part of the presentation that Tony Fauci did this morning, and I thought it was impressive, and I thought a lot of people said, you know, it was probably one of the best, easy to understand, you know, the mucosal area of the penis, which is removed and now becomes a different type of structure, essentially becomes more of a standard skin structure, which maybe was less well understood by most people. I didn't get the full gist of it until just today. But I think that partly explains some of the risk involved with an uncircumcised penis.
Absolutely. I think it was a very sort of graphic, in the best possible way, description of the anatomy and the implications. I think, you know, one of the things is coming to America from the UK, most Americans are not are circumcised. Said they, understandably, they can't quite work out the anatomy, and, you know, so a surprising number of people don't realise that the foreskin retracts in the erect penis into an area of exposure. So it's an interesting situation.
Well, it's been very nice to have you again, and I always appreciate your candor.
Yeah, you're welcome.
It's always great to have you.
Okay.
Thank you very much.
Nice to be with you.
Thank you, Ian.